That's not supposed to happen, just let me know. We're having some troubleshooting issues this morning, and I always tend to. Welcome everybody. Thank you for joining on a Saturday to learn about special care dentistry, which some of you might know about, or it might be something that you don't know anything about, and that's absolutely fine. Certainly when I was at your stage at university, it's something that maybe I didn't really have a clue about, to be honest. So I wanted to make today as interactive as possible, so no one falls asleep, and no matter what you were doing Friday night. So to keep you awake, I'm going to be using something called Menti. So I don't know if anyone's used it before, but it's a way for you to interact with me during the presentation. I'll be asking questions, there'll be a quiz, and you can follow the presentation on your phone or device as well as the Zoom. So, and you'll see at the top of the slide there that if you just go to menti.com and you enter that code, and then you should, so you can do that on your phone, on your tablet. You can open a separate tab on your laptop if you are, if that's what you've got to hand, and then you can log in, and then you'll see my presentation as well. And then if you just let me know when you're here, I can see 8 of you who are already here, which is fantastic, just when you click the like, and that would be great. And I hope this is a way for you guys to make the presentation nice and fun. And actually there'll be a quiz, so it'll be incentivize you to interact, and there might be something at the end of it as a prize for the person who gets the most points. So let's see, with 30 of you, how many on the call again, Nicole? There was like 60?
69 now.
69. So I'm going to wait for a few more people to join, but while we wait, I thought I would like to see, let me see if this is going to work. Please work. Next. Yeah, here we go. Okay. So if you can let me know which university you guys are at. You just type in, so you should see it on your phone now. Oh wow, great, fantastic. I'll be coming up which university. If you're not at university, if you're not a student, that's fine. Just let me know your stage or where in the UK you are, whether you're a DFD or a DTT. That's great. Wow, lots of people. I like this peace sign, whoever that was. So lots of you guys from Plymouth Peninsula representing. Anyone from Newcastle? I was there. So it's a DFT, fantastic. Teesside University, is that therapy? That's great. Yeah. Fantastic. Oh, wow, we've got 52 of you interacting. That's really good. Thanks, guys. I might move on now, unless anyone's not typed in where they're from.
Oh, we've got one from Uruguay as well.
Oh, amazing. International. That's incredible. I don't know what special care is like in Uruguay. You'll have to let me know, because I'd love to hear what your experiences are of special care. So if you guys could see on your screens as well, that you can just type in a quick sentence or something, what your experience of special care is so far during your degree. So that could be literally like me when I was at Newcastle, 0. It could be, you might have seen some patients, you might have some shadowing, nothing so far, that's absolutely fine. Do you even know have you ever heard of it before? Nothing. Work experience, great, really good. Work experience in a peds special care clinic. Okay, right, that's something I'm going to come on to in a minute when I talk about the remit of special care dentistry. Wow, there's loads of you. What else have we got? Nothing so far, nothing so far. Okay, 0 aside from dental related volunteering, surgery care, 0 lectures, special care teaching. Oh, we have someone who was a dental nurse prior to university. Fantastic. In a homeless mobile clinic. Wow, you're definitely on. Whoever's put that is my best friend already. Dementia patients shadowed. Fantastic. Okay, that's really good. I'm really glad you guys are interacting, because you weren't, this would fall flat. Similarly, if this technology wasn't working, it'd be a bit rubbish. Thanks so much, guys. So, I certainly didn't have any experience as I was an undergraduate, and I think that's normal, to be honest. In terms of Newcastle, we didn't get taught anything about special care, and even now when I'm supervising undergraduates on the KCL clinics, they do get some interaction with special care patients. But I guess the thing is, you guys are trying to master dentistry. You're trying to know how to wedge place your infiltrations, how to do a simple filling. And then a lot of special care dental patients are a little bit more complex to manage. So it's a bit unfair of us here. You're trying to master dentistry. Here's a really difficult to do it, a patient to do it on. But I still think it's really important that we're all aware of what special care is, what sort of groups these patients fall under, and where you can go for help, and what additional skills you could gain by seeing some of these patients. So that's what I'm going to cover today, why we all should have an idea of what special care is, my journey in special care dentistry, and I'm also going to go through some patients that I've seen and what my typical week looks like. So you're just aware, you might at the end of this go, oh, that's very interesting, but I don't think that's the right career path for me, or I'm not sure this is interesting, I didn't really know this existed, so maybe I should get some more information or learn something more about it. So it's really good that a lot of you have had some experience with special care, but not very much, and that's completely normal, so don't feel worried if you haven't had any experience with special care patients yet. So next bit, I'm going to go on to a quiz. You might hear some music, you might not. I've muted my. I think the technology might not be able to cope with music as well. So I'll leave that. Just imagine there's some funky music going in the background. So what we're going to do is a little quiz. So let's go on to the next slide, see if it works. Hopefully it works. Fantastic. So if you join my quiz, guys, so you can put your real name, you can put your fake name, whatever you want, and when you're ready, just let me know. I know 46 of you are ready. We're going to start a little quiz, and what this quiz is about is possible patient groups that fall into special care, and how many of them actually exist in the UK, and why is it important that we all are aware. And as I said, the person who gets the most points at the end. So this goes on throughout the presentation, so please keep following your mentee on your phone, your tablet or your tab. This will keep going throughout my presentation, and the person at the end will get a prize, okay? So keep awake. Hope your brains are all ready to start working. So let's go on to the first question. In 50 years' time in our population, how many people will be aged over 65? So it's a multiple choice one, this one, so get your brain stickings, make sure you're, oh, here we go. Oh yeah, it needs to start first, sorry, I need to press click start. Oh, fantastic. Most of you got that right. 1 in 5 people in 50 years will be over 65. That's impressive. Let's see how people are doing then. Who's at the top? Oh, everyone's doing pretty good. So if you answer it quicker, you get more points. I wonder if you choose your emojis or they just get randomly assigned to you.
I think it's random.
I like whose teeth. Mr. Dragon. Man, these are impressive names. So let's move on then. What's the next question? Oh no, I need to talk first, don't I? Sorry, I forgot you got to learn as well as have fun on a Saturday about special care. So in 50 years' time, there will be an increased number of people who are older. You've probably heard in some of lectures that we've had, certainly if you are any lectures by Health Education in England, that our population is getting older. And in 50 years' time, 1 in 5 of us will be over 65. And there'll be a population of people who are over 65 that's equivalent to the size of London on top of our current population. So we need to make sure that we are equipped for their needs, that we plan for their needs, and certainly, you know, if people are living for longer, and they might be living for longer, are they going to be living for longer well? Are they going to be fit and healthy all their lives? Or if they are going to live with longer with comorbidities, are they going to survive cancer and then have the repercussions of that? Or are they going to develop cognitive issues like dementia and Alzheimer's? So these are all things that I need to take into consideration, and this is one of the reasons why we should all care about special care dentistry. Right, next question. If it works, please work. So how many people in the UK have a learning disability? Yeah, is it going to go? Is it going to go? I think I have to do 3, 2, 1. Can you answer that? Oh, here we go. It's just a bit slow.
Yeah, it is working. Yeah, we got the time. Yeah.
Let's have a look. Interesting. So everyone thought that was much lower than expected. So 1 in 5 people in the UK have a learning disability. And this is from MenCap, and it's one of their most recent polls. And I guess learning disability, what do we all think when someone says this person has a learning disability? It's a big spectrum. So there's no right answer, but actually it's much higher than we think. And can all these people who have a learning disability, how do they access dentistry? Do they need to see a special care dentist? Can they see a general dentist? Or how do we plan for their needs, any additional needs that they might have? So that's another reason why we should all care about special care dentistry, when 1 in 5 of the population have a learning disability. Let's move on. Oh, who's at the top now then?
Mr. Teefs. I'm rooting for them.
Oh, fantastic. I like Halima's burger. That's a good one. Who's the Barefoot Contessa? Whoever that is. Interesting. And there's a goat. The goat's doing quite well as well. So that's differentiated the leaderboard a little bit. Sorry, must be on to the next question now. Or do I need to talk about something else? I think I've got another question. Yeah, we've got another question now. Let's have a look. So how many people in the UK have a mental health problem? I think I give you 15 seconds to answer.
Yeah, I think it is, yeah.
So let's see. It's something that we all talk about much more, don't we? We're all willing to talk about mental health issues, and we all should be. So let's have a look what people have done. Oh, excellent. Much better, guys. 1 in 4 people have a mental health problem. And majority of you got that. And that can, of course, is similar to learning disabilities. Mental health issues are, again, a spectrum, from people who have anxiety or depression, which might not affect their dental treatment that much, to people who actually have severe mental health problems, schizophrenia, bipolar disorder, personality disorder, other mental health problems, eating disorders. Like, these all fall under the remit of special care dentistry. And actually, how does that affect the dentistry that we provide them? Can general dentists see them, or do they need to have any additional adaptations to the dental care they provide? So again, another reason why we should all care about special care when 1 in 4 of the population have a mental health problem. So let's see how everyone is doing. Not bad. It's pretty close now. Let's see who's at the top then. Leah and Nikita head to head there. Really good. Keep it up, guys. Let's have a look. What else have I got? What's the next question? I keep forgetting. Here we go. One of my favourite questions. Of course, this has got to be in here. How many people in the UK are homeless? And so this is something that if any of you guys follow me already will know that's something that I really, really care about. And I take this figure with a pinch of salt because this is what we define as people who are rough sleepers, when there's such a big definition of homeless people. Right, okay, that was a bit split between 1 in 500 and 1 in 200. But actually in the UK, 1 in 200 people are homeless. And actually that varies massively depending where in the UK that you're looking. In some areas in London, 1 in 25 people are homeless. And that figure is staggering. And the question is then, how does that affect dentistry? The easiest way for these people to access dentistry is to walk into a dental practice. But they have lots of comorbidities, and they have mental health problems as well, really closely linked. And actually, there are charities and things that can help. So if any of you guys have volunteered at Crisis at Christmas in the past, which is one of the services that I'm a co-organiser of, you will have known there are good charity works really doing really amazing stuff to help improve the access to care for this group of people. But should we be relying on charity to provide a basic health service for people in our country in the 21st century, in a country where we're so proud of our NHS? So again, we should all care about special care because how many people in the UK suffer from social exclusion. So let's have a look at that leaderboard again. See how we're doing. A couple more questions and then I'll start talking properly instead of just playing with the game.
I like it. It's good.
Oh, amazing. Nikita, look at you at the top.
Wow.
Amazing. Good stuff. Let's see then, we've got a couple of more. This one is not a multiple choice. You need to type in a number for me. So what percentage of people in the UK don't have any teeth at all? So they're a dentalist. They need, or they have, or they need complete dentures, for example. Just type in a number and let's see how many people get the right answer. Let's see.
I'm not confident anymore.
The thing is like, oh my God, how many people? Oh no! Oh, that's disappointing. Should I try it again?
Yeah.
Maybe it's crashed because it can't cope with them. Oh no, here you go. Oh. Sam, who got 6%? So we got 20. Wow, 40% of people have no teeth. That's quite high. 3%. Did anyone get it right? I should have put a plus or minus like 1%. Does that mean?
There's two people who one person got 5 and one person got 7.
Oh, that's not bad. I'll give you a pat on the back instead of points. So this is from the Adult Dental Health Survey from 2009. So to be honest, it probably is lower than 6. So the person who got 5, you know, hats off to you. That's probably pretty good. And if you look at the population 10 years before that, so if you're looking at the turn of the century, there were about 37% of the population had no teeth. So you can see that now has decreased to 6%, that people are keeping their teeth for longer. So whereas, you know, 20, 30 years ago, if your parent had to go to a care home, for example, they probably didn't have teeth. So in terms of the implications of someone looking after their mouth, you know, that there isn't much. They don't have teeth, so they don't need people to brush their teeth. Whereas now people are being admitted to care homes, or people living longer with complex dentistry, with failing dentistry, with bridge work, with crowns, with implants. And then what happens when they lose the ability to look after that themselves? Who's going to brush their teeth for them? Who's going to floss or do TP for them between their bridge pontics? Probably no one. And then what happens when that fails? Who picks up that mess? Is it going to be that dentist who placed those implants, who probably doesn't have any skills in special care? Or is it going to be a special care dentist who doesn't have any skills in implants? That's me. So it's tricky, and I think that's why, another reason why you should all care about special care, because if you are placing or doing treatment in patients that is expected to last potentially longer than them, you need to think about what's the future and plan for their care, and hope maybe pick things up when things start to fail. And that's what we're doing at the moment with special care dentists. So let's see, I think the next one is a type question, but you might be able to get this one. I think this is the last one before I start talking properly. So what systemic conditions are linked with poor oral health? So there are a few, so just type one in and then press submit, and there are a few, so plenty of marks. Let's see. So what illnesses or systemic conditions are linked to poor oral health? And I'm giving you more time because you have to type a little bit more now. Let's see, you've got 2 seconds. Fantastic, what have we got? Oh, someone's put in a whole list, amazing. So I put here, there is many correct answers. So let's have a look. Diabetes, dementia, amazing. Sorry, that person who wrote diabetes, I knew that you meant diabetes. That's autocorrect. You should have got the mark for that. Motor neuron disease. This is what established. Oh yeah, someone who's put CVS problem. You should have got a mark for that one as well. Ehlers-Danlos. Oh, or Ehlers-Danlos, however you want to say it. Diabetes, Alzheimer's. Life is linked to poor oral health. I like that one. Yes, to be honest, it is. But if you look at the evidence, if anyone's ever heard the Chief Dental Officer talk, and hang on, let's look at the lead board first. That's more exciting than what the Chief Dental Officer said. Amazing. Who's top so far? We're pretty close, actually, aren't you guys? So who we got? Lucy is at the top. Well done, Lucy. Oh no. Oh, I don't know what it's doing now. It's doing something weird, or is that that's my mouse? Anyway. So that's the last question for a little bit. So if you want a little break from Mentimeter, you can, but keep it open because there will be questions as we go along as well. But coming back to the stuff that I should be talking to you about is in terms of what conditions are related to oral health. There's plenty of good evidence to relate that links some really well-known conditions that affect the whole rest of the body to poor oral health and the mouth. And it makes sense. The mouth is a gateway to the body. As Sarah Helly says, we need to put the mouth back in the body. And we shouldn't be just treating our patients as walking mouths just coming into our surgery. Yes, they might need a DO filling, like who cares? Like the thing is how you need to look at a patient as a whole. And actually, if they've got good oral health, that can really impact that whole systemic health. So things like diabetes, really, really well known. So well done for anyone who said that actually diabetes and periodontal disease are really closely related. And it's a two-way relationship as well. So if you've got poor periodontal disease, you're more likely to get diabetes. If you've got diabetes, you're more likely to get perio. But if you've got diabetes and you can improve your periodontal state, that might actually improve your diabetic control. Similarly, cardiovascular diseases, infective endocarditis. Infective endocarditis is a really, really severe condition. I see patients with it because in the hospital, they ask us if anyone comes in with it, they ask us to screen them out to check if it's an oral cause. If you get infective endocarditis, morbidity rate is around 30%. So 1 in 3 people die when this get condition. And it's caused by bacteremia, so bacteria entering your blood system. And actually, oral bacteria can be heavily implicated in the causation of that bacteremia. So things like just chewing. If you've got poor oral health and you chew, or chewing gum, or swallow, or brush your teeth, you can cause a bacteremia that potentially cause infective endocarditis. Not to scare you, but it put things into perspective. That you think, oh, what's the big deal? You're doing a filling on a patient. They don't really care. Or you're doing a simple scale on a patient. You know, in the whole context of things, what is the big deal? But actually, in some patients particularly, if you really improve their oral health, you can improve their systemic health and reduce the risk of really serious conditions. Oral health has also been related with stroke, with cancers, with low preterm weight babies, and premature births as well. So that's really important that pregnant women really look after their oral health in this time. And most recently, there was some really good research that linked dementia and periodontal pathogens. So the bacteria that are implicated in periodontal disease have actually been found and cultured in the brains of mice who have dementia. So we don't really know fully understand the implication yet, but if you can reduce the risk of potentially getting dementia later in your life by just brushing your teeth and looking after your mouth, surely you want to do that. And then the other thing is pneumonia. Aspiration pneumonia acquired in the community or in hospital is something I see quite a bit for the patients that I see because of the patient group. And actually, I will talk about this later and in one of the cases that I've seen. But if you've got lots of bacteria and bugs that shouldn't be in your mouth, can you imagine what, that's a gateway to your lungs, that's a gateway to your GI tract. Surely that it makes sense that it increases the infections and the risk of getting other horrible diseases as well. So it's really important that we integrate oral health with whole body health. And that's really important, especially in special care groups. So again, another reason why we should all care about special care dentistry. So that is a brief overview of kind of the reasons our population dynamics and why we should all be thinking about how can we provide care for these groups who might be a little bit more difficult to manage. But I guess the next thing is we need to talk about what is special care and what I do. So we'll pause the quiz for a period of time, and I hope you learned something from doing the quiz, and it's not just a bit of me messing around with technology. So this is me. course, you know it's me. Please do connect me and reach out on social media if you want to talk to me about anything, because my door is always open. But I want to talk to you about why special care for me, because I guess you want to be me to answer that question, because if I hadn't had an experience, I've told you I haven't had any experience of special care as an undergraduate. Why am I training to be a special care dentist right now? So while I enjoyed university, I came down to London. I was like, okay, I want to work in practice, that'd be great. But I will go into hospital and do a year in community, seeing hospital patients, and then I can take those skills back into practice, and that'll make me a better dentist. And if you look at my career pathway so far, I guess I've kind of tried a lot of different things, and I guess maybe this brings on to the next slide. Let's see. Yeah, there we go. There's a slide of me. I'm sorry, it's lots of pictures of me. There we go. But I guess, so that's me in Newcastle University, top left. So shout out to any of my Newcastle crew here who are tuning in this afternoon. But I guess this is something that I'd advise anyone about general careers, is that if you don't, it's fine to not know where you want to go. People might be pressuring you in terms of, you know, where do you want to go? What do you want to do after graduate? What do you want to specialise in? Where do you want to work? But it's fine not to know, and actually your career and your decisions can change. And certainly, as I just said, like I'd never saw myself working in a hospital. I was like, I'm going to work in practice, but things clearly haven't worked out that way I thought they were going to be. And that's fine. I think I was steered by the mentors and the people I've met along the way. So, but I thought I would be someone who would try bits of everything and see what I liked. And I think that's something I advise to everyone. If you're not sure what you want to do, why don't you just try something? You don't know what you like until you try it. And then you can say, okay, I've tried this, I really enjoyed it, I want to go down that way. Or I tried it and I don't really enjoy it. So let's not pursue that avenue further. So I worked in hospital, I've worked as an associate dentist, I've done some private stuff, like I've trained in Botox and short-term orthodontics, which I did not enjoy. So I tried it and I didn't enjoy it, so it's fine. But that year in hospital, I think, really kind of shaped my career path from there. And I wasn't a special care dental trainee, because this was my dental training year. I was the general duties oral surgery restorative one. But over the year, when we're working in the walk-in department, if anyone remotely, I realise now, anyone remotely slightly special care came through the door, the head of department would say, oh, Natalie's good at seeing this patient, so let her see them. And so I became like, if anyone came through the door that fit that description, I would always see them. And I guess it made me feel like I really enjoyed seeing these patients, and maybe other people didn't, or didn't give them a chance to be able to see, and how fulfilling it is to see a patient who might have had their doors slammed in their face before in terms of trying to access care, or just needed someone to be more open and flexible and treat them like a human being. And I really enjoyed that, and that's what spurred me into getting experience working in community dentistry, and that kind of affirmed it for me, and that's why I'm now doing my specialist training. But I think there was one defining moment when I was working in the hospital that made me think, I want to do this for the rest of my career. Was the first guy who I saw who was homeless. He walked through the door, he was called Wayne, and he had toothache. And he'd seen 3 other dentists before coming to see me, or coming to the hospital as a walk-in clinic, and each of them had said, we can't see you, you can't pay, oh no, our books are closed, or you're homeless, we can't see you. And all I did was took a tooth out for him. It wasn't difficult tooth to take out. Couldn't replace it for him. It was a front tooth. But he left, he smiled, he had a gap at the front now, but he was so thankful, because before that, people had said no to him. He'd been self-medicating with drugs and alcohol to manage the pain that he was in. And still, in this country, in London, in the 21st century, I was amazed that someone who clearly needed basic healthcare couldn't get it, because people just weren't flexible enough, or weren't open-minded enough, or weren't listening to him, and weren't treating him like a human being. And so I'm sorry if anyone has heard me tell this story before, because I tell it all the time, but I think it was a really important moment in my career, because it helped, because that's why that's my why. That's why I wanted to get involved in these groups more. And my experience of treating people with advanced learning disabilities or dementia and stuff was limited before that. But special care groups are such a wide variety, and that once you get involved with one group, I think it makes you want to get involved in lots, because it's so fulfilling. And the pattern is these people struggle getting care. Doesn't matter what care it is. Doesn't matter if it's dentistry. Don't matter if it's they're going to register with a GP. It doesn't matter if it's something else. They struggle getting access to care, and just being that person who holds their hand out and says, "I'll see you," with a smile on their face is the best feeling ever when they smile back at you. So that's my why, and I think it doesn't have to be special care, but wherever you go in your career in the future, if you know what your why is, and it might be one defining moment like me, or it might be a series of moments or a period of time, recognize what that is and share it, because people want to know why you are where you are, what you choose, what you want to do, and that'll help support people in terms of finding what their career path is as well. So that's why I always share that story. Sorry to bang on about that, but I just thought it was important to you guys know why I chose special care. So I guess the next thing is, what is special care? Let me see if I can move this thing on so you don't see my face anymore. Yes, here we go. So special care dentistry, I was interested when one of you said special care pediatrics, because that's different. So special care dentistry, I only see people who are 16 years and up, please. No children. Anyone who you think might be special care, but it's under 16, that goes to my pediatric colleagues, and they're much better equipped at treating them than I am. Special care dentistry, I think, things to remember: 1, over 16. 2, it's all dentistry, so I do whatever dentistry my patients need. So I don't just take their teeth out, or I don't just do their dentures. I do whatever treatment they need, and that's one of the reasons I really enjoy it, because it's variety, and you're seeing the patient as a whole and treating them as a whole. And the other thing is, I'm treating patients who have an impairment or disability of some kind. And so this is the GDC's definition. So they have an impairment or disability which can be physical, sensory, intellectual, mental, medical, emotional, blah, blah, blah. Long sentence there. But just remember, it's a special care. Special care is dealing with patients who have an impairment or disability. And actually, special care or special needs is something that is a little bit of an outdated term. I think the more up-to-date one that people like to use, which was formulated with response with actually asking patients what they would like the specialty to be called, is patients with additional needs. You can imagine, if you come on to what groups fall under special care, which should be my next slide. Is it going to work? There you go. So if you see all the groups there, like if you are a dental phobic and someone says you're special needs, does that sit quite nicely with you? Probably not. Even if you have a medical condition, or you know, a housebound, you can't leave your house. Someone say you are special needs. No, I just can't physically get to the dentist. So that's why additional needs fits a bit nicer. And if anyone sees this sunflower, anyone watched me do the talk I did at BDSA, will know what sunflowers mean. So sunflowers mean patient has a hidden disability of some kind. So if you ever see someone with a lanyard that has sunflowers on it, I even saw them in the airport when I did travel just before COVID, luckily, that there was a line, there was a special queue for, said Sunflower Lane, which is very nice. So imagine if you've got somebody who has a learning disability, has autism, can't cope with waiting very well, doesn't like to be close to people, then actually having a designated, being flexible, having a designated lane for them is a really nice way of being inclusive and making a reasonable adjustment. So if anyone sees a sunflower, that's what that means. But in terms of special care, patients I see, we like seeing patients and putting them into boxes, don't we? I mean, you guys will be doing that at university. When you are seeing patients, you'll have your patient who walks in who will be, this patient is my PROS patient who I'm doing a lower partial denture for. This patient is my root treatment, the patient I'm doing a root treatment for. Not until later on, or when you start going into general practice, do you start taking ownership of a whole patient plan, unless you're at, I know it's slightly different, I know at Peninsula maybe in a new plan where you are based in primary care. But we like putting patients into boxes generally, but patients don't fit into boxes very well. And certainly the patients I see do not fit into boxes at all very well. You can imagine if someone has who might be stuck at home because of a physical disability, they're housebound, they've got a physical disability, they probably have a mental health problem, because if you're stuck at home, maybe that might be something that is a compounding factor. You might have a complex medical problem which fits with their physical disability and the reason why they can't get out of the house. So you can see, like, they all kind of mesh together. So although I've put these patients in boxes for you, none of my patients generally fit in boxes. They overlap quite a lot, which is why their care often can be quite complex. And the other thing with patients who have additional needs, let me just take a sip, is that, I'm sorry, this is the only graph, I promise, that is in the whole presentation, because I know it'll be boring otherwise, that patients who have additional needs have a much more oral health needs as well. So this is, if you look at, I don't know if you can see my mouse-ish, you look at yeah, you can see it, can't you? Bit lag. On the x-axis there, that's the number of teeth that are decayed. And then along the x-axis is things like their income, their occupation, and then here we've got our lovely special care groups at the end: long-term ill or disabled, homeless or in a prison. And you can compare, you can see that their oral health needs, their number of teeth that are decayed, are much more than someone who is a manager in an office without any additional needs, or the people who are at the highest end of society. So you can see, like, this is income, so as income decreases, then oral health needs and number of decayed teeth also increase. And so the same with special care patients. So not only do that we have increased population of special care patients, who are keeping their teeth for longer, who are living for longer, they have an increased burden of oral health disease. And who is going to look after that? Certainly can't just be special care dentists, because we're, if you look at the number of specialists, special care is very low compared to, for example, orthodontists. We tend to have 1 million orthodontists and not as many special care dentists. So that's why we should all care about special care. And if you did want to get involved in the specialty, why, we'll be open arms for you, because we need more special care dentists. So generally, where do I work? There were some King's peeps on the line. You'll recognise that tower block opposite Shard. That's Guy's Hospital. Then I also work in a district general hospital, so a small hospital based in Surrey, which is much smaller, and a community rehabilitation unit. So this beautiful building on the slide at the bottom is a hospital called the Royal Hospital for Neurodisability. It used to be called the Hospital for the Incurables, but thankfully, quite a few years ago, they changed that. But it still says it on the outside of the building, because it's a beautiful Victorian building. But this is where I look after patients who have brain injuries. So they might have been in a road traffic accident, for example, might have had a stroke. So it's based in community, but we have a dental department there. And typical week, well, when everyone asks me what my typical week is, I don't think that I can really give them an answer, because every day is different, every week is different, and that really is because of my patients. So I do all of this stuff. It could be all of this stuff in 1 week. Normally, this is pre-COVID, by the way. Not be doing a lot of this right now. But I treat patients with sedation. I treat patients with physical disability, so I need to use like a wheelchair tipper or a bariatric chair. We work with a big team of people, not only just dentists, but medical staff, and seeing patients who've just been diagnosed with cancer. So it's a really, really, really varied week. And if I was to talk about all of this, I know I'm going on already, just realised what the time was, but if I talked about every single one, you'd be here literally all day. So I'm just going to talk about a few of them, and there'll be some questions now. So I want to get your brains back ticking, and we'll get some more stuff on Menti. So if you could make sure you open your Menti again. I'm going to ask you questions again from this slide. So I just wanted to talk about sedation first. These are inhalation nasal hoods that we deliver nitrous oxide sedation. These are pediatric ones, but they come in adult sizes as well. And I love this picture because I love colours, but they're all different colours because they're all different flavours. They all smell slightly different flavours. Grape is my favourite. This closely followed by the orange, which is also an amazing colour. So it's always fun picking what mask to use when you're treating a patient. So I provide all types of sedation for my patients, whether that's inhalation, intravenous, intranasal, which is my favourite, oral sedation. We can do multi-drug sedation, or work with our anaesthetic team for them to provide the sedation while we focus on the dentistry. But I just wondered for you guys, I hope this works again, how many of you have treated patients before under sedation, or assisted or seen sedation before? Just so I can understand the audience really, and how much I can talk about this. So a lot of you not. And the numbers are still dropping down. People are falling asleep to my voice. So when I was at university, I don't know if Newcastle still do it the same, but we had a block of sedation. I think I saw one patient under inhalation and one under IV. But I love treating patients under sedation. Reason why, there's lots of reasons why you provide sedation, and that'll be my next question. Can anyone think of any indications for sedation? So you can type it in, and I can have a look and see if it comes up on the screen. Hopefully it works. Because there's lots of reasons why you might have sedation. And think about the patient groups that I've been talking about. So anxiety, phobia, yep. So if you're really anxious and you don't like the idea of having injection in your mouth or whatever it might be, of course, sedation might be useful. Can anyone think of anything else? Fantastic. Okay, great. Multiple tooth extraction. So yeah, if you're having a complex or quite horrible surgery, possibly more pleasant to have it with sedation. People with learning disabilities or people who are uncooperative, yeah, exactly. So who can't cope, and that's generally a lot of my patients. So generally I have a whole day normally of seeing patients under sedation a week, which is really, really fulfilling, and it helps patients get the treatment they require. What else have we got? Uncooperative patients, yeah, muscular disorders, so yeah, or a need to stay still. So patients who have got tremors. So if they've got Parkinson's, for example, and they've got a tremor or cerebral palsy, they have spasticities, then they need to be still so you can safely provide their dentistry. Weak analgesia effect. That's only for inhalation sedation. Okay. So only small amount of analgesic effect for inhalation sedation, but I wouldn't say that was enough for it to be an indication by itself, but very good for you guys to remember that. What else have we got? Sensory problems. So yeah, if they're very hypersensitive, having things in their mouth, then you can have sedation to help relax them so they can cope with it. Full mouth clearance, yep. One of the fun things, gag reflex, yep, fantastic for someone to remember that. So if you've got a really hypersensitive gag reflex, the sedation can relax them enough so it doesn't get triggered, so you can do the dentistry. Has anyone else said anything else? Nervous anxiety, muscular problems. GA can't be provided. Yep, I'll talk about GA in a bit. Implants, yep, really good. Tourette's, yeah, I've treated a few patients with Tourette's. So Tourette's aren't just it's not just swearing sometimes and coming out with an outburst, but sometimes they have like a tic when they do it, which can be the uncontrolled movements. Also, if patients have limited mouth opening or muscular problems where they can't open very wide, midazolam sedation from IV is a muscle relaxant. So that's why it's good for tremors, but it's also good if you've got a patient who can't open their mouth very wide as well, or is really anxious as well. It helps relax everything. But thanks very much for that. But sedation is really, really satisfying because all these patients have real problems managing having their dentistry, whether it's because of anxiety or phobia or all those things that we just talked about. And you can do the sedation and they can get their dentistry done. And it's also quite fun, seeing someone who is so agitated and then they're lovely and relaxed, and you can just get what you need doing, get what you need done. So if you have an opportunity as a student to go and work with someone who's doing sedation or treat patients in sedation, I would definitely advocate for that. The next thing I wanted to talk about was bariatric dentistry. So if any of you at King's, you recognise this chair in the Wallace room in our department. This is a bariatric dental chair. This chair can take up to 80 stone. So you can see it's pretty big. And this is for patients who are obese. So bariatric dentistry is dealing with patients who are overweight. And there's lots of dental implications of patients who are overweight. This can be simply that you need a chair that can take the weight, like this one, or you know, they have comorbidities, so you're more likely to have cardiovascular problem, diabetes, other issues medically that complicates their dentistry. And also even getting their dentistry done can be really tricky. You know, if someone's got a, you know, a really tight area, a massive tongue, lots of soft tissues, it's like wrestling an alligator to try and, you know, for your nurse, poor nurse, to retract the tongue out the way. How do you even do your ID block if you can't even see any of the anatomy because it's all just buccal fat bad? And they might have a high caries rate, because if they're continually snacking on cariogenic stuff, then of course their caries rate will be affected and they'll be at higher caries risk. But the question is, I guess, a question for you guys, if anyone follows me on Instagram, you will know the answer to the question. But it's going to add to your points again, so easy points for some of you. What is the usual weight limit of a dental chair? So that one was 80 stone. That's not normal. I think the most I've seen the patient actually is around 30 stone. Because imagine being 80 stone and actually being able to walk and get out of your house. I don't think that's possible, to be honest. So I think the record I've seen is someone who's around 30 stone. But what's the normal weight of a standard dental chair that might be in your dental school? Yeah, majority you got it right, 23 stone. But that can vary. I mean, you have to check your the weight of your dental chair, and the important thing is to ask. How many of you ask? I guess it could have been another question I asked. How many of you ask what the weight of your patients are? I mean, it's a bit awkward, isn't it? But we should know, because I have seen patient at dental school actually, a patient who was over the weight limit of the chair, and actually, if they're quite a big, tall, muscular guy, with, you know, who can be quite heavy, they don't have to be obese to be over the weight of the safe limit of a dental chair. And they popped him back in the chair, and then the dental chair wouldn't get back up again. And they had 4 nurses like pushing underneath to try and get the chair back up to upright position. So if the patient is over the weight limit of the chair, not only is it safety risk for them, but also for you and your team. So it's something that we need to talk about. Let's have a look at the leaderboard. Who was top last time? It was Lucy, wasn't it?
Yeah, Lucy.
Still top, just score a few questions so that you can overtake Lucy. Anyone? Just wanted to talk about physical disabilities a little bit. These are wheelchair tippers. So if you have a patient who is a wheelchair user who can't get out of their wheelchair, and you can't get into a dental chair, how do you provide the treatment for them? We have additional equipment that can help for these patients. So these are wheelchair tippers. The one on the right is the first ever wheelchair tipper in the UK, and that is the one who's based in the Neurodisability Hospital. And the one on the left, we recently got that in one of our hospitals. It's portable, so we can fold it up and just tuck it in the corner when we're not using it. And it also has like a bariatric bench you can slide into it, so it's 2-in-1. It can be a bariatric chair and a wheelchair tipper, so it's really, really good. And so the patient just stays in the wheelchair, you pop them into the tipper, and then the tipper just pops them back. And that lets us be able to do their dental treatment for them. If we don't have a tipper, I've also worked in places where we've had hoists. So that's when we are able to physically pick up the patient and move them and pop them into the dental chair. And we have other facilities that help people who have limited mobility as well, like other things to help people stand. And it's important to have the right training and equipment for to manage the care for these patients, which you wouldn't have if you were working in general practice. And so coming on from physical disabilities, I just wanted to talk a bit about domiciliary dentistry. So this is providing care for patients who physically can't get to your surgery. So this can, you know, this is me, look at me, my bright yellow children presenter raincoats. It's my favourite raincoats. We have to get, you know, going out rain or shine. I remember going out in the snow once, which wasn't fun driving. But it's going to people's homes who are stuck at home, and that can be because of physical disabilities, but it can also be because of mental health problems. If they're agoraphobic, for example, so they can't leave the house, and we have to take all that equipment. Look at that picture on the right. We take all that equipment with us: emergency drugs, all the kit, oxygen, clinical waste, sharps bins. So we have to take a lot of stuff with us, but it is the only way that some patients can actually get any dentistry. So the next thing I just wanted to ask you guys from that is, what sort of treatments do you guys think I do when I can go out and see someone in their house? Do you think I can do exactly the same treatments that you can provide while you're in your dental surgery, or do you think that it's different? So if you just tick the ones that you think I can provide while on DOMS, and just let me know. Let's have a look. Hope it works. Is everyone voting? Can you vote? Is it working, Nicole?
Yeah, it is working. I think we have to wait until the time goes down.
Oh, okay. Sorry. Been patient. You notice how the colour of the slides are changing.
It says please wait for the presenter to show the next slide for me. Oh, there you go.
There we go. So let's have a look. Yeah, lots of exams, scaling, fillings, dentures, extractions, root treatments, x-rays. So that's really interesting. I guess there's not really a right answer. It really depends on the patient. So you can imagine if they've got a grade 3 mobile lower incisor tooth, I'd be really quite happy to take that tooth out. But if it's something that I don't know the root morphology, it might be a big chunky tooth that I'm a bit worried about. What if it turns surgical? I'd rather be in a clinic really than doing that at home. So the important thing when you do domiciliary visits is making sure you have an appropriate risk assessment, which is a bit boring to talk about, but it's making sure that you're planning so that you are risk assessing what is a suitable thing to do while you're in this patient's house versus what actually I need to try and get them into a clinic to do. So I do lots of this stuff. We can do fillings so a lot of the fillings I do are just atraumatic, where we just place some glass ionomer. Some dental services, domiciliary dental services, have portable kits. I put the extra one there on purpose because I just wanted to show you this picture of me looking like James Bond with my x-ray gun. So this is our portable x-ray unit. It's called a Nomad. We use it in theatre, and we are doing the paperwork to try and get it so we can use it on a domiciliary visit as well. But there's loads of things to take into consideration and lots of paperwork. But this literally is a gun, an x-ray gun, so I can go and point it at your face and expose you to an x-ray. But as you can imagine, there's lots of paperwork and governance around organising and planning for us to use this. But it offers this flexibility, and it's really good that we have access to equipment like this. And then I just wanted to talk about my favourite topic, of course. How can I talk about special care dentistry without talking about outreach and mobile services? So this is the mobile dental van that I set up in East London, my old community dental service that goes around to homeless hostels and soup kitchens, providing care for the homeless. And my wonderful nurse there, Abdul, on the left. But outreach, I love doing outreach. It's one of my favourite things because I think it really helps you understand the patient more. You go and see them on their turf at their home, or in a care home, or in a special school, or in a soup kitchen, or whatever it might be, and you really get to know that patient and how oral health fits in with the rest of their priorities. So this is what we set up in East London, and I set this up because it was a much better way of delivering dentistry to this population versus trying to get them all the way into clinic. And certainly I know a lot of dental student organisations do kind of outreach stuff. In Newcastle we had Brush Up. I know Peninsula do stuff as well, and King's certainly have Smile Sock. So if you want to get involved in outreach, please do, because it's really, really fulfilling, and you really get to know the patients much better than when you're wearing a scary uniform in a clinic when they're purposely come to see you when they have a dental problem. Right, when you go on outreach, you go and see people when they don't perceive to have a dental problem, so you can try and do more prevention and stuff like that. So it's much more, I find it really, really fulfilling, and it's much more upstream in terms of the strategies we can do in terms of improving our health. And I guess in terms of seeing what the problem is, I put this map up. I won't go through this map too much, but just look where you are in the country or where your dental school is. The darker colours are where there's a really high population of people who experience homelessness. So as I said, in some areas in London, 1 in 24 people are homeless versus the average of 1 in 200. But look where you might be. I mean, I know down in the southwest, Cornwall has an issue, and coastal areas also tend to, strangely, look at the patterns along the coast, certainly tends to be much higher population. But also, that brown patch there, I think that's Birmingham, isn't it? So if anyone's from Birmingham, I can't remember if I saw anyone. shout out, but see, there's a high population there. Manchester, this is Bedford, I think, I'm not sure. But and Bristol, definitely a big population around Bristol. So homelessness is a problem, isn't just a London problem or a southeast problem. It's a problem that will affect all the areas that either you're studying in or maybe that you work as well. So I've got another question now. What percentage of people who are homeless have a dental problem? So this is from some really good research that a charity called Groundswell did a couple of years ago. What do we think? I hope this works. I'm scared my internet's going to stop working. Okay, good. So 90% of people seem to have a dental problem. That's really high, isn't it? So, and that's from going out to see people who aren't, this is when the research went out on and went around to rough sleepers around London. So it's not people who are presenting to a clinic. It's, do you have a problem with your mouth or your teeth? Yes, the majority of them do. And then concerningly, I'm going to ask this question. Oh, hang on, let's check out the leaderboard first. Let's see who's on top.
I bet it's Lucy again.
Yeah. Kate's catching up though. Look how close she is.
Yeah.
Let's see, we've got a question, another one. Everyone's ready for the next question then. This is a question I like to shock people with. What percentage of people who are homeless have pulled out their own teeth because of dental pain? Let's see. See if it works. Yeah, well done, guys. I think that's pretty, I was shocked when I read that figure. If you imagine like your whole dental group, like your year group, if well, Kings have a million people in their year, but like there's maybe 150 in a King's year, so that's like looking around and saying maybe just over 20 people in this room will that lecture theatre have pulled their own teeth out because of dental pain and they haven't gone to a dentist, and that might be because of their own personal choice, but it might have been that they can't get access. And on top of that, there was another figure that said another 6% of people had their teeth pulled out by somebody else who wasn't a dentist because of dental pain, which is really shocking. And access is a real problem for this group of patients, and that's the problem I want to solve by the research that I'm doing as part of my MSc at KCL as part of my training, but as well as the social enterprise that I've set up. And if anyone wants to also contribute to that, please do, and just follow me. And if I, in terms of when opportunity arrives, that if I want people to get involved, I of course reach out to you guys. I'm really happy. I'm really keen to get younger dentists and students involved in helping promote oral health in this really, really vulnerable group of patients. So let's have a look at that leaderboard. Was Kate overtake? Oh, look how close! Yeah, Kate's overtaken Lucy. Oh. There's still a few more questions left, guys. So let's see if anything changes. There's going to be like a dark horse come and overtake both of you guys. So the last kind of group I just wanted to talk about before I talk through a few cases and do last few questions was going to see patients on the ward. So I know many of you study at dental hospitals where your experience of hospital dentistry is a dental hospital, or you might work in a primary care base like a plan or something like that. But actually, once you start going on the wards and seeing patients in hospitals at general units, it's really, really eye-opening. And actually, some of the foundation dentists who I've spoken to who have been redeployed to like the Nightingale and places. So that's actually really, really interesting to see how hospitals work in general and how wards work. So we have an arrangement in all the hospitals actually that we work at, that we can go see patients on the wards if their medical team are worried about a mouth care problem. We are a team as part of Mouth Care Matters. I don't know if any of you have heard Mouth Care Matters, but it's a program, a quality improvement program to help improve the oral health of hospital inpatients. So we have a mouth care lead nurse who goes around and makes sure that all the staff are trained in providing mouth care for patients who are in the hospitals, because patients who are admitted to hospital, they're at high risk of certain mouth problems, so dry mouth and stuff like that. And so sometimes we get called to the wards if they're worried about a patient who might have pain from the mouth or they're struggling with something. So look at that prescription on the left there. I'm going to come back to that in a minute, but have a really good look at that. And I'm going to ask you a question about that prescription in a minute. If you look at that, before we talk about that, let's talk about the kidney dish on the top there. That is a patient who I went to go see for, we do screening sometimes, so we go to the ventilation unit at one of the hospitals I work at, and just go around and check everyone's got toothbrush and stuff like that, and if they have any mouth problems we can manage it. But in that kidney dish, it's all that patient's personal hygiene effects. This patient is ventilated. I think they were being rehabilitated following it was either locked in or Guillain-Barré syndrome, something like that. So they were low level of consciousness. They had a tracheostomy, so they had an airway into their artificial airway into their windpipe here. So they couldn't communicate. And this is all their stuff. So you can see there's a razor there, a comb. Yeah, of course, people who are in hospital for a long period of time, like this patient, would have had stuff like that. That green thing there is their toothbrush. And then that thing on the left is a mouth prop to help when the nurses are doing mouth care for them. So yeah, there's toothpaste in there as well. And that bit of cream, that tube of cream that you can't see, that's their pile cream. So if you were this patient, would you like your toothbrush there that has been sitting next to your comb, that's been brushed, you know, they've been using to comb your hair, that razor that's been like shaving your face, and that tube of pile cream that has been, you know where, to be sitting next to your toothbrush, and then someone puts that toothbrush in your mouth, and then you can't tell them because you're unaware, or you've got a low level of consciousness, or you can't communicate because you've got an airway in. I mean, how would you feel if that was you? I certainly think it makes me get goosebumps when I think about it. And it's not because the people looking after this patient were doing it on purpose. Just didn't realise. But as soon as you take that kidney dish over to the matron and say, you know, that toothbrush has just been sitting here. Like, oh, okay, no, okay. Why don't we store it separately? And simple solutions like that can, you know, it's not being passive aggressive or anything. It's or you know, patronising them. It's helping find solutions to things that maybe they just didn't think of before because they're not trained and thinking about the patients that we see in terms of their oral health care. So I'm going to ask you a question about that prescription. I hope everyone's had a good look at that prescription chart. So that's all the drugs they've prescribed by their doctor. Did anyone spot what's wrong with it? And don't say, when I show that slide to doctors and we do the mouth care training, go, oh, propranolol was spelt wrong. That's not what I'm looking for. Yeah, perfect. Yeah, did everyone spot that? That the indication for Corsadil was tooth decay. Is that right? We know that's not right. And this is all not just about training the people who are on the wards looking after the mouths of these patients, but training doctors. Doctors don't know anything about mouth care. And that's not just being mean. It's because it's not, you know, we've done surveys and they don't have any sort of mouth care training or dental care training as part of the undergraduate curriculum. So we do training for them to help in terms of make sure when they do prescribe something, it's indicated. So we know that, you know, Corsadil is not an appropriate appropriate to prescribe in someone who's got tooth decay, and they didn't have tooth decay anyway, they had calculus. And also making sure they actually look in the patient's mouths. The amount of times that we see doctors prescribe nystatin, so an antifungal, for these patients, when the nurses go, oh, there's a white coating on their teeth, and the doctor says, okay, it must be thrush, let's give them nystatin and Corsadil. And actually, when we come down, what is that white plaque? what is that white coating? It's just plaque. So they just need a toothbrush. They don't need, of course, still a nystatin. And actually, in terms of exposing someone to a drug that they could potentially have a reaction to, and also cost for the NHS. One ward that we did this audit on for, in a year they spent £7,000 on prescriptions for nystatin and cortisol, and then when we did the mouth care training, that pretty much almost went down to zero. So what else could we spend £7,000 on in a hospital? There's plenty of other things I'd rather spend it on than cortisol and mouthwash when we don't need it. So special care dentistry is not only just treating the patients, it's working with the rest of your team, and we're much more medically orientated because we're much closer contact with the medical teams for these patients, whether it's managing their care and planning their care, or simply because the patients that we see are using other medical services much more. We have to interact with them and come into more contact with them. So I think that is moving on to cases now that I've realised the time. So, and I know you probably want to do better things with your Saturday than listen to me talk and watch a pink screen. Although, who's it? Lucy and Kate doing quite well out the quiz. There's some more questions coming up in these cases. But I just wanted to go through 5 cases of sorts of patients I see and how we might manage them, because I think they're quite interesting. I can talk about, you know, all the settings that I work in and the different treatments that we do, but actually seeing that applied to patients might be more interesting for you guys. So I wanted to start with the first case. Oh, hang on. No, I'll go back. That's not what I want. Okay. Too quick on the voting. So the first case is a 26-year-old male. He had severe agoraphobia and learning disability. So he has not left his house in 7 years. So he's got severe learning disability. We managed on a domiciliary visit to have a look in his mouth, but it was quite limited due to cooperation. And all you can see are some broken anterior teeth, so some broken roots there, but he has not left the house in 7 years. So what do you think would be the best treatment options? So this is a slightly different question structure. If you can just rank what you think is the most appropriate first. Sorry, this makes me think of SJTs. So most appropriate to least appropriate, of what you think would be good for this patient. So they've got a clear dental need. And the other thing I want to say is that we weren't sure if he had any pain or not, and I'll come to talk about that in a minute. So there's no, his mother didn't think he might have any pain, but this person, he has such a learning disability that he couldn't communicate that with her, so he's non-verbal. So let's see. Have you voted, Nicole? Is it working? What does it say?
I was just going to say, I was just going to say that on my screen I've just got case 1 and then the bullet points. Does anyone else? Maybe someone could write it down if they can see something different.
Yeah. How about that? I clicked a different button.
At the moment it's the same. Anyone else? Oh, okay, someone said I can see the answers, haha. And someone said they can just see case 1.
Okay, let me try and work this out.
It seems like different people seeing different things. Weird.
Let me try and do this way and go back again.
Yeah, thanks.
See anything different?
Okay, I'm just going to refresh. No, yeah, seems like people get just seeing case 1. It's weird.
Oh, okay. Maybe my internet can't cope with. No, just see case 1. Oh, sorry. Okay, let me try and reload as well. Oh yeah, it's doing something.
Some people can see the options, but
there's special people.
Yeah. I think some people aren't even. I don't know. Weird.
Are you seeing the answers still? Okay. If not, I can just talk through it.
Oh, okay. I've got a question on now.
Okay.
Yeah. Thanks.
Cool. Need full screen. Oh, hang on. Make it over here. Sorry. I can see it properly. Oh no.
Oh.
No, don't want to see myself. Cool. Is that all right? We're back to.
So your screen isn't up, but I've got the options on my screen, but your screen share stopped.
Okay, let me work this out. Oh yeah, I can just see my face. Don't like that. Don't like that. Share. I thought I'd mastered it. Let's try this.
Yeah. Okay, I think it's going to start off again.
Cool. I mean, quite a few people have voted, so it must be doing something.
Yeah. Like Lucy and Kate, probably.
Treatment and domiciliary visit. This is interesting. Treatment and sedation. GA. See. So I guess the things to consider for this patient is there's a clear dental need. Look at that age, they're 26. So, and otherwise he's fitting well actually as well. He's not taking any other he's not taking any medications. He's just taking some vitamins, I think. So is there a chance that any broken teeth or any dental need are going to flare up in the future? It's really quite high. But how are we going to get him to get his dentistry done? He's not been out of his house for 7 years. We can't even get a good look in his mouth to see what the actual issue is. If we could do treatment and a domiciliary visit, what would it be? I mean, he's got broken off roots. You know, we're thinking about extractions possibly. And if they're roots, what's the chance of them turning surgical? And do we have enough cooperation to actually do that in the first place? So this is a really difficult case. And if any of you follow me on Instagram, you will see that it got published this week in a journal. What we did a domiciliary general anaesthetic. And certainly this is not something that I think would be, if you're ever in a Viva and someone talks about treatment options, definitely don't say this first. Because I think, and I know one of our services that's done one, but it's a lot of planning that takes place, and it's really invasive. So there might be other options for a lot of these patients, but this patient, we tried to get him out of the house, we tried to acclimatise him, giving some mild sedation to get him to the clinic, but it just wouldn't work. So ultimately it took 2 years of planning to be able to go to his house, and you'll see this how many people are in his front room. They're not social distancing, are they? Obviously they were not possible, but that's Jack's front living room, and they put him to sleep at home, and then we brought him to the hospital and saw him in theatre, did all his treatment while he was asleep. We took a lot of teeth out, did a lot of fillings, and then they took him home sedated, and then he recovered him at home. And that took a whole day and a lot of planning. And we went to see him the next day, and he was fine. I don't know if he had even realised he'd left his house, or he just woke up again in his front room a little dazed, not sure what's happened. But it's interesting what his understanding was. So Meg, who is the dentist who went to see him with the anaesthetic team to put him to sleep, who you see there, who's looking in his mouth, she gave him the pre-med, she gave him the oral sedation before they could put him to sleep, in his favourite cup with his favourite drink, which was orange cordial. And then the next day when she went home to visit him on a review, he beckoned her into the kitchen, poured himself an orange juice, then drank it in front of her, and then waved at her as to say, I'm drank it now, you can go. Whether he was anticipating a similar event going on when she came to view him again, I don't know. But it's so interesting because we have assumptions that, you know, Jackie's non-verbal, he won't let us look in his mouth, really. He can't communicate with us. So you assume that he doesn't understand what's going on, but maybe he does. He just can't communicate that to us, or we don't think like Jack thinks. So I always think this is take a message. You don't ever assume you know what a patient is thinking, or don't assume they don't know what's going on, because you just don't know. Just because someone can't communicate, they could understand perfectly well what's going on. And the interesting thing with these broken roots, we took out about all of his anterior teeth because they're all broken down, because all he ate is jam sandwiches and sausages. And he had a swelling and a cyst and on one of the incisors. And from the first time we saw him to the time that we actually got to do his treatment, he had grown a moustache. And I thought that was a bit weird. Why would a family think, you know, I'm going to give someone a special design on their facial hair when they've got a learning disability? I don't know. And maybe, now we were talking with his mum, maybe it was that he started refusing letting her shave it about a year after we started seeing him. And maybe it was when she was pressing the razor over where she would shave over his lip, that she was pressing with the razor down on the swelling, and that hurt him. So it's like a bit of a detective novel, putting things together to think, is there a dental problem? So in patients who can't communicate, like if they have a learning disability or if they've got dementia or something like that, it's saying they can't tell me if they're in pain. Let's see if there's any changes in their behaviour that might give us a clue that they might have a dental problem. And that could be they've stopped eating, that could be that they're hitting their face on one side, it could be that they're drooling more on one side, it could be they're waking up with blood on their pillow, it could be that they've got a moustache now. So it's something I've learned from this case, and I think it's really, really, really interesting. So because I would never have thought that. So I learnt lots from seeing when we managed Jack. So I hope this works now. We're on case 2. Can you see that, Nicole?
Yes, yeah.
Yeah, perfect. And that lovely picture.
Yeah.
3 people have liked that picture already and haven't even started talking about it. Nice. Case 2. Oh, look, I've gone crazy now. Loving this picture. Oh no, hang on. Click the wrong picture. Right, here we go. Go back again. So this was a 21-year-old that I saw in the neurodisability hospital, I think. He had a traumatic brain injury following a fall. So it's quite sad actually. He's 21, he was on a stag do, and him and his friends got very drunk one night, and then he fell off a balcony onto his head. And he's had his brain injury. He had a cranioscopy, so he had a part of his skull missing to relieve the pressure on his brain. And it's funny that he's got low level of consciousness and neurodisability. So it is actually quite sad, a lot of these patients that you see, because he was quite an attractive guy as well. So it's really, and his mum visited him every day. She travelled all the way from Ramsgate to see him every day in London. So it's, breaks your heart sometimes. But we saw him as a screening visit. Oh, he had invasive ventilation, so he had a tracheostomy in, and on lots of medications, as you can imagine, for someone who's got brain injury, confined to a wheelchair. And then we look in his mouth and we pull out that from his palate. A lovely picture there that 19 of you have liked. 20 of you have liked. So what is it? Someone's like, blood clot? Okay. I want to see if anyone knows, get me the right answer and what that is. What that lovely picture depicts. Meninges. Interesting. We got it from his mouth. Brain. Brain. This is interesting. Cyst. Nerves. So it's just from his palate. Sinus ooze. Oh, that's close. Rhinorrhea. Okay. Question mark. Specific disease. Interesting. Cyst. Mucus. Excellent. Someone got it. Snot. Yes. Pretty much. Oh. Mucus. This is great. I took this picture and I was like, I wonder if anyone's looking at my Google Photos when it backs up and go, oh, what is she loading pictures on? But I can't put that one on Instagram, can I? So that was so this chap, he's ventilated. He has a tracheostomy. So he has, they want to keep that patent. You don't want anything to block it. And we're worried about his swallow. So people with brain injuries or people who've had stroke or people who have dementia often their swallow reflex is rubbish, or they have no cough reflex. He has no cough reflex. So if anything goes down the wrong hole, if anything goes down the lungs, whether that be saliva, whether that be your respiratory secretions, whether that be water, that can get into his lungs and then cause pneumonia. And that's aspiration pneumonia. So aspirating things that shouldn't be, and that can cause lung infections. And if you're ventilated, you're much more higher risk of getting aspiration pneumonia. And what happens, so what they do to prevent that is, this picture here is, doctors put these patients on medications to dry up their saliva and dry up their secretions. So ignore, this is a chap getting some Botox into his masseter to help with mouth opening, and that we do at the hospital as well. But look at the patches underneath his ear. They're called hyoscine patches, and they dry up saliva. And patients can also be given oral medication like glycoponium, which again, it dries up secretions so that it reduces the chance of them getting aspiration pneumonia and keeps their airway patent. But if it doesn't only just dry up secretions in their respiratory tract, it dries up their oral secretions as well. And it only affects the serous part of your saliva more than your mucus part. So the nice runny clear saliva that we have, that dries up and you just have the mucus that your saliva glands producers still. So you can get builds up of secretions in the mouth that can look like kind of mucousy, snotty, like that one. Or they can dry up and they look horrible, dry kind of spider webs. And imagine having that. We don't know how long that mucus plug for that patient has been there for. His teeth were immaculate. The ward staff were cleaning his teeth really, really well. They just didn't look in his palate. And why would they? But imagine he can't communicate, he can't swallow. He's got a huge plug stuck in his palate. How uncomfortable would that be? And it's really straightforward for us to remove it. But it just really demonstrates the importance for these patients of looking in their mouth and making sure it's nice and moist and comfortable because of the problems that they have. So I just thought I'd give you, that's the goriest picture I've got in the presentation, I promise, guys. So on to case 3. So we've got a 92-year-old male, so he's quite old, it's impressive, got to 92, but he has advanced Parkinson's, he's non-verbal and quite cognitive decline, so can't communicate with him, he's quite kyphotic, so that means he's very bent over, which is very typical, stooped posture of someone who has Parkinson's. He doesn't walk, he's confined to a wheelchair. He lives in a care home, and we can't look in his mouth because of his posture and his cooperation. But he comes with his daughter, and his daughter says that in the morning she noticed blood on his pillow, and his eating habits are changed. He's not really eating any solid foods anymore, and he's not got very much of an appetite. So let's have a look. Let's see. I go to the next slide. This one. I hope you can see this one.
Yeah, that worked.
Excellent. Got it right now. Perfect. So ranking, what do you think what should do? Should we leave them and monitor? He's 92, so how long has he got left? I mean, that's a really sad thing to say, and what's the indication? Do we actually know he has a dental problem? Do we try and have a look in his mouth? But we can't look in his mouth just normally because he's not cooperative, so we have options there, maybe a sedation or general anaesthetic. So I'll leave it for a little bit for you guys to vote. There's 27 of you who are still voting and really engaged still. So I guess the thing with this guy is you have taken into consideration his age, his complex medical problems, and his dental needs. So he's very, very old, and he's also very unwell. So you could argue that leaving him as he is, even possibly giving him antibiotics, even though we don't know if there's a dental problem, weighing that up, is that more kinder for him versus invasively treating him? So treatment under general anaesthetic carries its own risks. You're giving someone medication that basically paralyzes them and stops them from breathing. And people who are older have a reduced capacity to compensate for this. The risks are higher, plus he has all these medical conditions. Plus when patients who are older wake up following general anaesthetic, there's this risk of something called delirium, where they can get very unwell, they don't know where they are, very disorientated, and that can prolong their hospital stay. Sedation, maybe that's better because you don't have to, it's less invasive, you can control the amount of medication you give them, but it depends on their treatment need. If they then have loads of teeth that needs taken out and they're still not very cooperative, what are the options? So I'll tell you what we did for this patient. It's really difficult making decisions for patients who are older, who have really complex needs, but we decided to see him with our anaesthetic team and treat him in sedation, to have a look in his mouth and do any treatment that he needed. We gave him 1 milligram midazolam. So if anyone's done any sedation clinics, you'll know that's minimum amount of drug that we gave him, and that was enough so we could look in his mouth, and we took out 2 teeth. One, we had some broken off roots that had a PA area when we took the X-ray. And then he recovered, and we sent him home. Unfortunately, later that day, he became more unwell, and he got admitted back to the hospital. And then 10 days later, sadly, he passed away. And when I tell the story, and I've written this up as well as a case, we go, "Oh, you killed a patient." I'm like, "No, we didn't kill a patient." There has been an investigation. They said that the dental intervention that we did is not related at all to the fact that he unfortunately passed away. He's very ill, he was very unwell, and he's very frail. And his daughter agreed, and thankfully he was on our side as well, which made it easier. But it does make you think that should we have just left it? Would he probably, the same result probably would have happened if we hadn't done his dental treatment. He probably would have died very soon anyway. But there was an indication. We looked in his mouth, we gave him very minimum amounts of drug that we could, we got medical supervision and opinion, and there was a broken off tooth with an infection with it that potentially would have caused him pain. But actually, maybe on reflection, the fact that his appetite was decreasing wasn't because of a dental need, probably because he was just coming to the end of his life anyway, which is very sad. And again, it comes to the fact that in special care, we often have to deal with situations that you're not trained to deal with, and it can be quite, you have to build up resilience for it. And decision making is not easy at all. But having seeking opinions from specialists, with medical teams, it's the support and doing what you think is right at that time. And should we have seen that patient again, probably we would have done the same thing, because there was an indication that he was blood in his pillow, his appetite was changing, is an indication that possibly he had a dental problem. And he did have a dental problem, but sadly he did pass away. So we often are dealing with patients who are very unwell, and that does happen sometimes, not to leave it on a back burner. But don't worry, I've got some more upbeat cases next to talk about, and a picture as well. Cool, lovely. So we've got case 4. Have a look at that picture and I'll talk through the history. 65-year-old female. She has Sjogren's syndrome and rheumatoid arthritis. So I will just recap if you haven't covered Sjogren's yet in your undergraduate training. Sjogren's is an autoimmune condition that affects salivary glands and other like your tear glands as well. So they have reduced salivary function. It's autoimmune, and rheumatoid is autoimmune as well, and they're linked as well. So she has autoimmune conditions on many medications, but previously she had been taking alendronic acid, which is a bisphosphonate drug, but she's not taking it anymore. She stopped about a year ago. And she's also taking steroids, which is very common. Patients with autoimmune conditions often are on steroids to suppress their immune system. She's had these roots in the upper right quadrant for a while, and she has denture covering them. They're not giving her problems. They've been there for a while. But she has noticed in the past week another tooth coming through. So that's what I can imagine, this thing here that you can just see. That's a bit weird, just around there. And the gums look a bit inflamed, don't they? She's not had any pain from this. It's just a bit uncomfortable because the denture sits on top of it and it rubs. So it irritates her, so she stopped wearing her denture. So let's see, another quiz question for you guys, if it works. Hopefully it's going to come up. What is your diagnosis? What do you think that is? So I've given you a bit longer to type your answer in. Hopefully it works. What do you guys get? Emerald, bronze. Yeah, it's emerald. Let's see how many of you guys got that. Roots erupting, exposed, so emerald. Bronze is the old-fashioned term. I'll come to that, but it's still the correct answer. So you guys got it. Roots erupting, supernumerary tooth. Interesting. Necrosis of the jaw. Who put necrosis of the jaw? You should get that. You'll get my pat on the back for that, because that's technically correct. And someone who's written emerald in full should have wrong. I like that one. Wrong is right. And yeah, so that is emerald. Or yeah, let's see the leaderboard first. Who's overtaken? Ooh, let's have a look. It's getting tight at the top there. Oh, still be Lucy and Kate. Get it, who's catching up as well?
Yeah.
So that is so you can see it's a different view here. I apologise. I'm not the best person. I don't take as beautiful pictures as some other cosmetic dentists. This isn't very cosmetic anyway, is it? Look, so you can see those roots there. They're, you know, how black they are, nice and arrested. They haven't given a problem, but you can see here, and that weird like hair thing attached to it. Nice. This is an area of exposed bone. So for those of you who haven't come across emerald yet, or Bronze. Hemorrhage is medication-related osteonecrosis of the jaw. It used to be called Bronze because it's bisphosphonated related, but there are lots of other drugs now who've also been implicated, so that's why they changed it to medication-related. So bisphosphonates and other drugs like denosumab are generally prescribed for patients who have arthritis. Also can be prescribed for patients who have got bony metastases and cancer or multiple myeloma and stuff like that. And what they do is they change the metabolism of the bone turnover. And what can happen as a side effect of that is if there is trauma to an area, that can cause the bone to necrose and break off and potentially become infected. So we mostly think about hemorrhage when we take teeth out, and that's the reason why we haven't taken those two roots out, because although she's not taking alendronic acid now, so that's the oral form of bisphosphonate, she has been taking it for a long period of time, and she's also on steroids, which compounds her risk factor. So we didn't take those teeth out. So you then ask, well, she's not taking the drug anymore. Why is her risk profile, has it got less? But if you take oral bisphosphonates, they stay in your bones for up to about 10 years after you stop taking them. And because you imagine they get integrated into your bony structure, your bone turnover is really, really slow, especially the older you get, especially if you've got a bony condition like arthritis, because they're trying to slow down the bony growth so you don't get breakdown. So it makes the bone really dense and strengthens it technically, but then it reduces the blood supply. So any trauma to it can't heal as well. So she got that because actually when she brought her denture in to show me at the follow-up appointment, the flange of it had broken and the bit that was sharp was rubbing straight onto that buccal side of the tooth there. And that had caused this bit of bony secrestia, this necrotic bit of bone to poke through. The definition of hemorrhage is that it's there for more than 8 weeks. I don't think that's been there for more than 8 weeks. So technically you could say that's not actually hemorrhage yet, but if it had been there for 8 weeks, it would have been hemorrhage. So I took that bony bit out. I did have a picture of that, but it's not very interesting. Just got rid of that loose bit of bony fragment, curetted it, and then I reviewed her a few months later and it had healed over the top, thankfully. But that's really something that you guys will need to know of and manage, because lots of patients are taking these drugs, mostly for arthritis is the most common. And if you want to learn more about management of it, the best place to look at some really good guidance that Scottish Dental one have done, SDSET guidance, really good document on managing patients taking the drugs that can lead to medication-related osteonecrosis of the jaw. So I'm going on to the last question and the last chance for some bonus points, so we can see how this 2-horse race is going to go, or if it's going to be a surprise winner at the end. And let's see, so it's your last chance to engage, so make sure you get your mentees ready. Comes with another lovely picture for you guys. I hope everyone's had their lunch already, because I'm sure you don't want to eat your lunch after seeing my presentation. So case 5, 51-year-old female. She's had a stroke recently. So she's in a rehabilitation ward. So she's been in hospital for a while, and then she's been moved to our rehab stroke ward, and she's been there for the past 3 months. She's non-verbal, but she's recovering and she can understand. She just can't speak yet. We're walking by, going to see someone else on her ward, and when she sees us, points at our dental badges and then points at her mouth. So we're like, okay, she wants us to look at something in her mouth. And then we look and we take out this implant supported overdenture. So when do you think the last time this has been removed? It's probably before she had a stroke. What do you think? Oh no, I'll talk about this and then hope my connection comes back for the last question. So you can see here all this plaque and debris collecting underneath the denture that hasn't been removed for I don't know how long. If you look at the teeth surface of it, they're actually really, really clean. So her team, the team in the ward, were actually brushing her teeth. They just didn't know that this should be removed. They thought that was her natural teeth. So there's 3 months of plaque and food underneath there. Look how uncomfortable that must have been for her. The smell when we took that out was not pleasant. And I was going to ask you a question. Let me just see if it works, whether I need to reload it. Can you see it on Menti?
Yeah.
Okay, cool. So what the fact that all of that rubbish underneath her denture, what does that increase the risk of in this patient? and it's not been removed for 3 months. Last question. Get your questions in, get your points in. Excellent. No one said COVID. Fantastic. Or someone said messaged me privately and said COVID. Interesting. So yeah, it really increases the risk of pneumonia, aspiration pneumonia, what I was talking about earlier, all that bacteria, all that gunk underneath that denture, sitting in her mouth. She has a poor swallow already. She's just aspirating loads of horrible bugs. She'd actually had pneumonia twice since she had a stroke. So you could argue it might be because of the fact that no one's taken the denture out. But it was tough. Even when we took that denture out, it took a while. And initially we were like, is this a bridge? Is this a denture? And then it popped out. And then we showed the ward staff how to take it in and out. And then we went back down about a couple of days later, and it hadn't been taken out because they couldn't take it out because it was so difficult to get it out. So it became our task between the dental team for a few weeks for one of us to go down twice a week to take it out, clean it and put it back in. And you could argue that you could have left it out for her because no one could clean it, but you could argue, would it slow down her recovery, reduce her self-esteem? Would it not fit then eventually when we come to put it back in again? And actually, getting her swallowing again, integrating with the speech and language team, it's better that she had her teeth there and that we just cleaned it every few days. It's not ideal, but again, special care dentistry often isn't working with gold standards. It's what's realistic and what's the best for that patient at that time. And it was until that patient then got her more rehab, her physio sorted, and then she was able, thankfully, to take it in and out herself again. So then we didn't have to go down and take it out anymore because she could do it herself. But also comes back to show that don't make assumptions. She'd had a stroke, she couldn't talk, but she understood everything. Like she knew that pointing at us, she knew we were dentists. She knew, and it's like come and see my teeth that haven't been taken out, and she couldn't communicate that to anyone else. And just because we were there, we could it was lucky we were, and recognize that she had a problem and we could help her. So let's have a look at who's the winner then. Hopefully you can see this. Can we see who the winner is?
Yeah, I think it's loading.
Stuff.
Oof.
Oh, Lucy, there you go. Last minute swooped in. Congrats. So Lucy, if you screenshot that you've won, post it on your story and tag me on Instagram at natb990. Sorry, gone a bit crazy then. I'll DM you and we can organise your prize. But well done, and thank you everyone for interacting. I hope that has kept you awake. I've only got a couple more things to say and then we'll answer any questions you have. But I'm thankful that technology has worked. Got a couple more things to say before everyone zooms off. I'm sure I'm talking too much. Well done, Lucy, well done. Let's talk about challenge of the special care. So as you can see from these patients, it's unique challenges in managing them. Firstly, in terms of there's lack of evidence. So there are some guidance that's out there, but you imagine doing research on patients who can't consent for themselves or who are very frail and elderly, who don't survive their cancer treatment or whatever it is. So sometimes what we are doing is mostly expert opinion and our own kind of experiences informing what we do. And often there's not a right answer and you have to make difficult decisions, like in that case of the patient with Parkinson's. Getting access for these patients is also very difficult. I've talked through that a lot in terms of getting them to see us in the first place. Many of the patients have to rely on other people to advocate for their needs, and if they don't have the right support setup or the right pathways in place, getting them to see a dentist who can actually cater to their needs is really difficult. And actually there's a huge variation across the country in terms of what is available. I'm really lucky that our services can pretty much provide a full complement of options for our patients, from cognitive behaviour therapy for people with phobia to sedation to general anaesthetic to wheelchair tippers, but not all community dental services or special care services have every single thing of what I just talked through. So that might limit the options. We have to build resilience. You see, these cases that I've talked you through can actually take its toll on you, taking these patient stories home with you, managing patients who have been through so much trauma or gone through such horrible events in their life, whether that is that they've been evicted and now they live on the street, to someone who's had a freak accident and now is highly disabled. So you have to kind of learn to leave the work at the door and try and turn off at the end of the day and not take all those stories home with you. And I'd love to have a crystal ball, like with that guy who has Parkinson's, like not knowing actually should we have treated him or not, would the result have been different, how long has this guy got to live, are they in pain or not? And there's so many questions that are difficult to answer in special care, but that also makes me love the specialty as well, because you often have to then think outside the box about how you can get this patient to manage the treatment that they need and cooperate, or manage what, or cope, or what is achievable for this patient, and maybe lower your expectations of going, I can do an absolutely beautiful composite on this person, to I can shove a GRC with my thumb. Like, that is literally sometimes what is achievable for some patients, and that doesn't mean it's wrong or negligent. It's what's treating that patient as an individual and getting to know them and stabilizing as best as you can. And then I think finally, I just wanted to talk about maybe things that you guys could do if you were interested. I might have just put you off special care, especially with all those pictures. But if you wanted to get more interest in special care, what you could do, there's societies like these ones that you could join. The BSDH does an essay prize for students every year, for example, and they usually have wonderful conferences, although I know this year that will be different. Get an experience as an undergraduate, see what clinics you have. It might not be that you have a special care part of your training or a facility in your hospital, but can you get more experience at community clinics, for example? Or if there's someone comes in who is a bit more difficult to manage because they might have a mental health problem, or they have a complex medical problem, instead of saying this isn't something that I can do, maybe it's something that you can do with support, or you can go shadow somebody in a department who's seeing these patients, to try and get experience as an undergraduate if you can. Sedation general anesthetic as well, really, really good experience to get. Volunteer, so I talked about Crisis at Christmas, but it doesn't have to be dental. Volunteer as a dementia friend, to go to your local care home and just be a companion for them. Volunteer at the soup kitchens, giving out food to people who are vulnerable or homeless. Volunteer as a Samaritan or something like that. Get experience managing these patients, not in a dental way, but just maybe just having life experience of them. Because certainly one of the core trainees who I work with now, she said to me our first special care clinic, like, I've never had to interact with someone who has a learning disability, and it was quite overwhelming for her. And so, which is fair enough. Like, if you've never had any experience working with someone with additional needs, like, it can be daunting and overwhelming. But if you get that experience outside of dentistry first, and if you do see it in dentistry, it's a double. Challenge the stereotypes. I've talked about that loads during my talk, so I won't bother on about that. But just think of that patient as a whole and holistically. How does their mouth and their oral care fit into the rest of their life? Is it a priority or not? Or what can I do and what can I achieve for this patient? And so those are all stuff that you guys can do if you wanted to get more experience in special care. And the other thing that you can do is, at the moment, I haven't announced this yet, but I thought it would be good to announce you guys while you're watching, is I want to run a competition with this essay. Well, I'm not going to say an essay, let's do a blog. Essay sounds really daunting, and blogs are much more formal, and it's much, the word count is always much less as well. So I don't know if any of you guys have checked out my blog yet. A Tooth Germ, as Nicole said, I've been posting kind of COVID diaries for the past few months, which has been really, really interesting. But I'm really passionate trying to get special care into the curriculum more for undergraduates, and not just for dentists, but therapists and other people as well, who work in the profession. So I wanted to know what you guys think. Well, why should special care be part of the undergraduate curriculum? And if you've been here listening to me talk for the past hour and a bit now, so you will have a head start on anyone else who when I post this publicly on my blog later. They've not listened to me yabber on for giving you the answer for the first part of the question. So please just, if you want to enter, I'd love to hear your submissions. The best ones will be published, so you get publication of it on my blog. I'm going to give you guys until the end of August, so that means, you know, no matter where you are in terms of your undergraduate career, whether it's your final year now and you're technically a dentist, which congratulations, but you can still enter if you want to. If you've got time, it's up to you, and just submit them via my email address there. And the winner, which I'll announce in September, will get a free one-on-one coaching session with me. So I haven't talked about this yet, but I won't talk about too much because you don't really care. You'd more hear about talking about special care. But I do offer careers coaching for young dentists and interview preparation, which I do to support you guys in your career. So the winner, whoever wins this competition, will get a free one-on-one coaching session with me. And then I'll leave it at that. We can open to any questions. But I'd love to see your submissions. Any questions about it, please just do let me know. And that's done.
Thank you so much, Natalie. Just before we go into questions and answers, I just want to say really, really huge thank you again to you for this amazing presentation. I really enjoyed it. I haven't been to a webinar this interactive, and I really like that website. So thank you so much for working through all those technical difficulties and getting it working. Thank you so much. And I've linked your Instagram and your blog in the chat for everyone to use if they want to. And yeah, so we'll take, I guess, questions if you're happy to. Yeah.
Fantastic. Can you see them? Because I'm if I come out my screen, I want to leave that on just in case anyone wants to take a picture of it.
Yeah, we can share it as well. I'll share it on our Instagram too.
Cool. Right. I'm on the questions. Let's have a look. So someone asking about whether a dental hygiene therapist fits in the team for additional needs. Yes, I definitely do. We work with therapists who offer inhalation sedation, for example, for some of our patients. Actually, prevention delivered to these patients is often best done by a DCP rather than a dentist. So there's definitely, in community dental services, we have definitely interaction with the whole dental team is really, really important. I guess it's you can also get involved in society, similarly what I've just talked about, going to CPD events, and then that shows your interest, and then you can apply to hospital posts or CDS posts as well. Similar, I mean, it's very similar to what a dentist pathway would be, but there's definitely a place for DCPs, and we use our DCPs a lot, like our mouth care lead nurse. She's a nurse, but she's amazing, and she works with our patients a lot. She goes out to care homes and helps prevention and events there and training. So it's not just the patient care that we could use it for, but it's also for training of the rest of the profession and medical team as well. Malaka, asked, what is the traditional pathway to specialise in special care? So special care is a 3-year training pathway. In order to, if you look at the CopDen website, there's a personal spec that has a full remit. So if you want to specialise, but generally you'll need experience working in several different specialties, and a few years behind you. You need to be a good general dentist before you consider special care. So if you imagine you put a patient to sleep in theatre and then they need a wisdom tooth out and you're a bit worried about it, you're a bit screwed. So you need to be able to do the dentistry first. And so they asked for a general good grounding in general dentistry, working in different specialties in a hospital, and career and experience working in community, and seeing special care groups is really important as well. And then it's you apply via the national recruitment process. So usually you will need to do at least like maybe 1 year of dental training as well. And then you're a three-year training program before you sit your tricollegiate exit exams and then you're a specialist. And we don't have consultant training at the moment, so that's probably a good thing. One less exam to take at the end of it. But that's the traditional route for special care. Hi Nikita, shout out. Very well, thank you so much for everyone who's saying thank you. Ramita, hi Ramita. I was wondering if it's mandatory to have done a DCT1-2 post in special care CDS specialising later. I didn't do a DCT1 post in special care. I still kind of saw special care patients. So if you can imagine all those patient groups I just talked about, many of them sometimes slip into the other specialties. So oral surgery, for example, you often manage patients who are very medically complex. You see patients pre-cancer. Same with restorative. You might be restoring someone following their cancer therapy. So they do fit. You just have to demonstrate that you see the patients as part of that specialty. But some experience in CDS is really looked on favourably, because that's the bulk of where our specialty sits. So it's not mandatory, but it's definitely something. If you look at the CopDem website in the personal spec, it gives you what the mandatory ones are. Can you get involved in special care as a GDP? Yes, definitely. First thing I would say, if you want to get involved in special care as a GDP, if you see anyone who's remotely special care that comes through your door, don't automatically refer them onto the community dental service. Sometimes these patients need to, and that's absolutely fine. But the amount of times sometimes patients who are special care just need a little bit more time, a little bit of acclimatization. Imagine someone who has autism, they might be able to cooperate fine. I have one guy who has autism who was referred, and all I need to do to allow him to have his treatment is let his dad stand in front of him with a mirror, and he watches everything that I do, and he cooperates absolutely beautifully for his treatment. And that's what a GDP could do that. It's just working out how that patient can manage their care and asking the right questions. So speak to the patient, speak to the carers, see what you could do that you could adapt to what you would normally do. So keep your patience, like be patient, acclimatize them, give them more time. I definitely recommend that. And then, well, I was going to say something else, and engaging with like events as well. Am I actually on the chat now? Can you hear me? Have I just been talking to nobody for the past 10 minutes?
Yeah, we could hear you. It was just paused. Like your video was just paused.
Okay. It's because I'm trying to view the video and I've lost the phone. Yeah. Now I've lost the questions. Were there any other questions that I've missed?
So you just answered, you did the SCD as a GDP, and then we just got a new one in from Nikita Joshi. Did you? But you just wait a minute.
Okay, I'm on it now. Sorry.
Yeah.
Any particular attributes one needs to specialise in special care? Do you ever get worried that you may come across something you don't know? There's so many medical conditions, yes, and medications around. I definitely, that's so true. Like, that's what my Syndrome Sunday is for. So if you follow me on Instagram, you'll know what Syndrome Sunday is. But it's going over, like trying to revise those things in my head, because we see, especially at guys, actually, we see lots of kooky, weird, rare syndromes that come through that you know, I look at it and go, what is that? And it's fine to admit, I don't know anything about this. Let me talk to the medical team who manages them. Let me look it up. Let me find a paper and read up about it. So there's definitely loads of things I come across that I don't know about. But it's then knowing where to understand. Don't expect yourself to know absolutely everything, especially in training now. I'm protected a little bit, but even my consultant sometimes is like, I've not heard of that syndrome before. Or what is this medication? Let's go look it up together, and just being open to speaking to other medical teams. I think to be a special care dentist, I'm biased, but I think you have to be nice. Like, I don't know a special care dentist who isn't nice. Like, what I mean by nice is like, friendly and open and welcoming and flexible. Flexibility, like special care is the flexible specialty. You have to be flexible. Because your patients don't fit into the boxes, they don't do what everyone else does. They have all these additional needs and problems that you have to deal with and integrate into their care. So you just need to be flexible and be a good generalist. So I love making sure that everyone knows what special care dentistry is and is aware of it and is interested in it. But before you go, I want to be a special care dentist, is like, I want to be a good dentist first. And so you need to master all those things, like doing a good filling, making a good denture, and taking teeth out. You need to be good at all this stuff before you think, I want to see these patients, because then any dentistry on top of that is much more complex, because you have to manage the patient themselves on top of it. So a simple instruction on someone who can sit open and open the mouth and cooperate will turn into a difficult one on a patient who won't cooperate, who moves all the time, who's got a bleeding condition, like, for example. So you need to be able to master the basics before you decide you want to be a special care dentist. So I hope that answers the question. From Anya, is it viable to apply following 2 years in DCT, or would you recommend a couple additional years in practice? If you look at the personal spec, 2 years in DCT is the minimum. Although I didn't do DCT2, I was working in community, but it's the same thing. It is viable, but it just you might be able to pick up more, it might be more straight, but you'll be more a generalist at that point. So a couple of years in practice is good, or in community is even better. I worked in community and practice at the same time before I did my specialist training, to keep my speed up, to keep my skills up, and just to keep my options open. And it wasn't until I got to specialist training that I not work at my practice anymore. So I think it just gives you that flexibility. So I think the other thing with careers is not think you can do one thing or another. Like I know there's something on Instagram soon that's like DCT or associate. Why can't you just do both? Like that's what I did, and that might not be for you. Like I don't think people think you need to choose early what you're going to do or between options, but actually think flexibly, think outside the box. I think this is going to be something we need to talk about more because of how COVID is affecting our future career paths. Will there be split DCT posts now because we can't see so many patients? Does that mean our DCT training is going to be our core training and other trainings be extended? And then but does that open up spaces in your diary to do other things? Does that mean that you can also pick up a day or two in practice, or a day in community, or not do dentistry for a day a week and do 4 days a week or 3 days a week? So just think inwards, think about what you think you can do, but don't think what everyone else is doing, I need to do that. Think what you want to do. And if you're someone like me, I think I like solving problems. So I recognised this yesterday. I like finding problems and solving them. So I'm always like, okay, well, how can I do both if I want to do both? Oh, I can find a way if I just think outside the box, and that's special care as well. And who else have we got from Anya's? What is the best place to seek community jobs? Look on NHS jobs for any community jobs. That will come up as community dental officer jobs. And similarly, if you want to shadow in the community and get more experience in your local areas, if you find out who your local community dental service is, so if you literally just type in community dental service or special care dentistry in your area, it'll come up with the local trust or site organisation that provides it, and then you could always try and, when post-COVID, contact them if you want to shadow or do any work experience or electives and stuff like that as well. It's just finding what's in your local area. I think have I answered all the questions, Nicole?
Yeah, from what I've seen, I think you have. If anyone didn't have their question, also just copy and paste it in. But you've got one more message.
Do you think they would let you shadow as a DFT? Yeah, why not? Don't see why not. Maybe not now, but I would if you're a DFT and you want to shadow, like see what your educational supervisor, your trainer, or your training program director think as well, because they might know someone and then they can link you. But I don't see why not. We had and are looking to in the future as well. And our community dental services have DFTs come in as a rotation shadowing, like on our mobile dental unit in East London, the BART students, I don't know if any BART students are watching, they come and shadow in third year for like a session normally. So I don't, obviously the band's not out at the moment, so who knows. So it's just if they say no, then fine, but I think they would. If you show a genuine interest and say why you want to do it and what you're going to get out of it, if you put it in your PDP, if you're a trainee, if you say I want to get more experience in this, between you and whoever's supervising you to work out how you can get that experience. So if you want to shadow as a DFT, as a dental core trainee, as a dental student or other dental professional, I don't see why they would say no. Maybe not if you all apply all at once though. That might be a bit awkward. Will post-COVID related changes affect special care? So yes, differently to primary care. Definitely. If you imagine all these patients I've just been talking to you about, how many of them fall into shielding category? Pretty much all of them. So that's we're planning at the moment to try and see how we can get back to a normal, and whatever that new normal is looking like. How do we approach a patient and build rapport with a patient who's got additional needs, who's got a learning disability, when we're donned with all our PPE on and we can't communicate? It's going to be really, really difficult. And certainly at the moment we are doing more domiciliary visits for our shielding patients. So where a patient might not have been a domiciliary, truly housebound patient before COVID, we are now going to see them at home more, to avoid them bringing them to a hospital where we are seeing patients with COVID. So it might be more domiciliary visits. how do we do things virtually for a patient who's got special needs or additional needs? Like our oral surgery colleagues are doing virtual clinics. How do we get a patient who won't even sit still in the dental chair or who's frail to look at a camera and engage and open their mouth? It ain't going to happen, is it? So I think our groups are going to be affected much more than general practice. I've been meaning to write a blog post on this, never get around to it. Maybe someone can write me a blog post about that. The consideration of special care patients for COVID. But yeah, it's going to be really, really difficult. And all these people who found care really difficult to access, like people who experience homelessness, we aren't doing outreach at the moment, so we can't do any prevention, outreach, in-reach work that we normally do. Patients, all the stuff we even communicate to our patients is in written form in the English language. What if you don't speak English? What if you're got poor literacy skills? What if even you have a sensory impairment? What if you can't see properly and everything's written down for you? Like, there's all these things to take in consideration until you put yourself in those patients' shoes, you wouldn't realise it. So sorry for rabbiting on about that answer to that question, Nikita. It's a very good question. But I think it will disproportionately affect our patients versus general practice. But yeah, maybe I'll stop talking now because I just think it's 4 o'clock. Wow.
Yeah, well, yeah, it's about 4 o'clock. Wow, I didn't even realise. Thank you so much for answering everybody's questions. Thank you to everybody who's stayed on. Like Natalie says, please get involved with the competition. That looks really good. I mean, that is definitely a really good prize as well, because I didn't mention this in the introduction, but I know you're a fantastic coach as well. So, you have that linked in your Instagram bio, I know that. And also, you do work with dental tubules as well. Yeah. And I think some of your webinars are, like, some of them recorded, right? I think with dental tubules.
Yeah, so go on tubules. I've done some lectures on, it's mostly around paediatric stuff when I was working in more peds. So there's a whole technique one. And the next few days I'm upcoming, there's a couple of ones which I'm doing with 90-day dental about special care. So if you want to learn more, I'm going to post them on my Instagram when they're up. I think one's literally just been published as I've been speaking. So if you want to learn more about that as well, I will be posting that. But anyone has any burning questions, of course, if you just want to reach out personally, my door is always open.
Yeah, absolutely. Thank you so much, and congratulations on the publication. That's amazing. That's really great on a Saturday. Yeah, and thank you so much, because like I said before, you're the first person that when me and Matt were talking about this series and we wanted to have someone talk about special care, we were like, please, we really hope that you would get involved. So thank you so much for giving up your time to talk to everyone. I'm going to stop this recording now, and thank you once again to everyone who's coming, and I'll send out the link for the recording afterwards.
Perfect. Thanks everyone for tuning in.